Good day, everyone. I hope you're doing well and hope your studies are going well with your last podiatry class. We're getting ever closer to your first midterm. So, this today is going to be a discussion about podopediatrics. Okay, start off with some housekeeping as normal. So, since you're good enough to listen to this, let's start by giving you a heads up on the midterm. So the midterm is going to consist of 40 trauma questions and 38 total podopediatrics cases or questions. 3 of the podopeds questions are going to be bonus questions. So watch out for those at the end of the test. So that's going to be a total of 78 questions, with 75 of them working towards your grade and 3 as bonus. This will be all multiple choice, no fill in the blanks, nothing strange, just a pretty straightforward multiple choice exam. These are the topics we covered in trauma. If you pause this for a second, you can kind of work your way through it, and this really just covers the variety of topics that we've really discussed, from everything from basic fundamentals, covering things like compartment syndrome and burns and Achilles ruptures, soft tissue injuries, all the way up to fractures, starting from the toes to the metatarsal phalangeal joints, midfoot, metatarsals, all the way to the ankle, including malleolar fractures as well as pilon fractures. So this covers the whole gamut of foot and ankle trauma. And as I made you aware, as you've probably seen already, there are a zillion classifications for trauma. Lucky you. You need to know every classification that has been discussed in this class so far. These are the primary ones that we talked about, everything from the Rosenthal classification of nail trauma, distal tip fractures of toes, through MPJs, metatarsals, Liz Frank, navicular fractures, talus, and ankle, including the soft tissue injuries like the Kawada classification for Achilles ruptures and the Castillo-Anderson classification for open fractures. So there are a lot of classifications, and the fact that there are a lot of these should give you a giant hint that a lot of your questions are going to be classification based. Okay, now the pediatric section was slightly different in the sense that we're covering just kids. You can take a look again if you pause me and see the topics that we covered in peds. This included everything from the examination to milestones, superstructural deformities like genuvarum and valgum and how you compensate for those things, all the way down to various bone issues, determining the age of a child based on the radiograph, and then also including everything else about the foot and ankle and diseases like talipes equinovarus or clubfoot, including other disorders that cause issues such as spinal dysraphisms. So there's quite a lot there. If you've been studying as you go, this should not be too difficult for you. The thing I like to kind of point out, and we'll see this in some examples in a minute, is that a lot of your pediatrics is really just straight out memorization. It's hard to reason through some of these things. So, you can't guesstimate what a kid's milestone is for the first time that they walk. So keep that in mind. This section requires some memorization. Okay, now pick of the week. This is a book called Skill, which is by an orthopedic surgeon named Christopher Ahmad. He is a upper extremity surgeon primarily. He specializes in the Tommy John surgery for elbow reconstruction. And he is a very successful orthopedist as well as a teacher. He works a lot with residents, and he trains students as well. And he created this relatively short book that is a quick read, very easy. Um, I would definitely suggest taking a look at this if you have any extra time, as you get towards the end of your second year. You take a look at this because you can really apply a lot of what he says to your own training and education. So in skill, he has these 40 principles. He has a statement at the beginning of each one to sort of organize you, and he breaks this up into three parts. And so the first part is where he talks about defining skills, and this is sort of like attitudes and basic things that you should do to prepare yourself for learning skills and for maintaining excellence. So, for example, he suggests to always carry a notebook, which is something that your professors here at Western also suggest when you're in clinic. In part two, he talks about improving your skills. So, how do you make a skill better after you've gotten it? One of the examples of this is that he suggests that you slow it down. So he suggests when you do a particular skill, say something like suturing or dissecting or something along those lines, that you perfect your skills in slow motion before you become really proficient. And what slow motion does is it really picks out the things that you don't do well, and that's what you focus on. The third section he talks about is about achieving mastery, and he talks about a variety of things, including things like grading your surgery. So this could be surgical, but it could also be non-surgical. So you do something, maybe you're in clinic, you see a patient, you can grade yourself as far as how well you think you did, and you focus on those things that you did not so well in order to improve for the next time. I love his very positive attitude throughout the whole book. He says, for example, that mistakes are building blocks for growth. He suggests that you cherish the greatest tool for improvement, which are your mistakes. And that is absolutely true. Nobody learns from doing it right the first time. So the more mistakes you make, the more chances there are for growth. And eventually, as you get better and better at what you're doing, you will become, you'll make less mistakes, which is good as you attain mastery. Um, but if you never focus on those mistakes, you'll never really achieve anything on the order of what Dr. Ahmad is talking about. So that is my pick of the week, skill. Okay, let's talk about some pediatrics issues to help you sort of along your studies. So, one of the topics is about primary ossification centers. So, when do bones ossify, and in what order do they ossify? So, it's an important question, and I learned this mnemonic way back when I was a student, and this mnemonic is described as Cat-Cull-Mins. So the CA is calcaneus, T talus, CU is cuboid, L is lateral cuneiform, M is medial cuneiform, I intermediate cuneiform, N for navicular, and S is sesamoids. Now the metatarsals and the phalanges are ossified at birth as well, so keep that in mind. It's just not included in this mnemonic. So if I want to know which ones are present at birth, so it's those first three, calcaneus, talus, cuboid, are present at birth, and of course that also includes the metatarsals and the phalanges. Then, well, if I want to figure out kind of how old a foot is, or kind of look at an x-ray and see kind of how old the child is, it's helpful to start to learn what comes next and at what time. So the lateral cuneiform generally begins to ossify at 4 months. So if you want to make it easy, just think 6 months. Then medial cuneiform at 1 year, intermediate cuneiform at 2 years, navicular at 3 years. So 1, 2, and 3. And then the sesamoids start ossifying at 10. So keep that in mind. If you see, if you're asked a question, say like, oh, I don't know, on a midterm exam, and they ask you how old is a particular child based on the radiographs, you can start to figure that out based on these kind of average dates. So Cat-Cole-Mins, that's your a helpful mnemonic for you. Now, what about epiphyses? So remember, everything we're talking about were primary ossification centers, and the epiphyses are secondary ossification centers. And this table should help you with that. So if you screenshot this or copy it, and then if you take a look at this, you'll start to see that there are some trends that are very helpful for you. So remember, these are epiphyses, not metaphyses. So for example, the distal tibia, the tibia is already partly ossified at birth. But the distal tibial epiphysis starts to become visible at 4 months. So it's just kind of an example of the epiphysis. So if you look at these, you can kind of see that the metatarsals all are very similar in their timing of the epiphyses. Somewhere between 2 and 3 to 4 years old. And same thing with the digits. So the digits are somewhere around 1 to 4 years old at the latest, but really most of them are around the 2-year-old range. So 2 years old is sort of your date of first appearance of epiphyses, of metatarsals, and phalanges. And then if you'll notice, the average date of closure for the epiphyses is really around 15 years old for just about everything. So, posterior talus a little bit earlier, but a lot of these really are closing at around the age of 15. So keep that in mind as you're, as you're thinking through these. If you have a child who, has some issue and they're concerned about growth plate, their average closure of pretty much all of the growth plates are going to be around 15 years old. Easy to remember. Okay, so let's take an example. Here's one. Forget about the large phalanges that are cutting across the screen. That's somebody holding the child's feet. So if I ask you how old this child is, you could see that the talus and the calcaneus are present. The the cuboid is present. That's that little small round bone that's just proximal to the fifth metatarsal. Obviously, the metatarsals and the phalanges are present. So this child's born. And there is a small early ossification center, and that's the lateral cuneiform. So remember, we had said from our mnemonic that the talus, calcaneus, and cuboid are present at birth, and the lateral cuneiform is around 4 months. And if you want to, kind of fudge it for yourself to make it easier, this is around 6 months. So I would guess that this child is somewhere around 6 months to maybe a year old, but probably around 6 months. Now let's take a look at a different one. Let's say you have a child that comes in and they complain of heel pain. They're an active child, and you see this, and if someone had not told you how old this child was, you can start looking at this. So the first thing is that just about all of the bones are present. And there's even very small early sesamoids that are present underneath the first metatarsal head. But there are still growth plates. So there's the apophysis of the calcaneus. And if you go back and look at that chart, you'll see that around 6.5 years old is where this started. Okay, so we know it started sometime, but it hadn't ossified. So that was around 15 years old. So we know that this child has to be younger than 15. Same thing on that distal tibial epiphysis. it is not ossified yet. And if you look really carefully, they're very thin lines, and that thin line actually represents the proximal epiphysis of the first metatarsal. Remember, the lesser metatarsals have epiphyseal plates at the distal end, and the first metatarsal is proximal. So if I were to see a child or somebody tells me I'm supposed to see a child who has heel pain, they're athletic, the first thing I'm going to think is that this child has Seaver's epiphysitis, and that would put this child at somewhere around 12 to 15 years old. So if they were 15, the growth plate would be closed. So we know they're younger than that. I can see that again, the sesamoid's there. That means this child's older than 10. So I would probably put this, if I had to guess, at somewhere around 12 years old. Okay, that's age. Now let's talk about osteochondroses. You have to know the names of every osteochondrosis that we're talking about in this class, and you have a couple of resources available to that. So here's a little test for yourself. Can you find the osteochondrosis named after Kohler? Okay, there you go. That's the navicular. What about Diaz? That's the talus. Freiberg, or Freiberg's infarction, is common to the second metatarsal head, while Iselin is the fifth metatarsal apophysis, and I already just mentioned a minute ago that Seaver is for the calcaneus. Now there's a whole bunch of others that you need to know, so don't forget about those others. Now, I wanted to bring up a couple of topics that potentially could have been skipped or might have been given some short shrift. So the first one is about the pseudoepiphysis. And as you can see where this is pointing, the pseudoepiphysis is an accessory epiphysis that's located in the distal aspect of the first metatarsal. And this is it is an epiphysis, but it doesn't actually contribute to growth of the metatarsal. So that's why it's called a pseudoepiphysis. Now, why do you need to know this? Because if you saw a child with a pseudoepiphysis, and this starts to ossify at around 10 years old, you might incorrectly think that this is a fracture. So you don't want to misinterpret the pseudoepiphysis for a fracture. Okay, now the pseudoepiphysis is usually in long bones, so the only one that we really have to be concerned with in this course is the pseudoepiphysis of the first metatarsal. Remember that it doesn't contribute to the length of the bone, so it's really just something to watch out for and be cognizant of in case you see a child with this problem. And then there's another normal finding that may be interpreted as a fracture of a growth plate. So this is called Kump's hump or Kump's bump. This is named after the doctor who first characterized this in the 1960s. His name was Kump. And what this is an undulation of the anteromedial aspect of the growth plate of the physeal plate at the distal tibia. And this is normal, and the reason it occurs is because this is the first area of ossification, and when you start to see ossification begin, at around that 15-year-old range, kind of in there, when you start to see ossification occur, you may see a Kump's hump. And again, you don't want to misinterpret this as a fracture of the epiphysis and call this a Salter-Harris 2 fracture. This is just normal, so don't mistake that. Okay, now heard something about there being a few questions about rotational disorders, um, about trying to interpret compensation, and there are really kind of two concerns or two issues with rotational disorders. The first is at what level is this disorder really coming from? And then the second is going to be about compensation. So I have a couple of pictures here that kind of show different rotational disorders. Uh, the 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 legs and feet in the middle is essentially normal. There's slight pathology. Um, so let's start with that. When I am looking at a child who comes in with a complaint of in-towing, first I'm going to remember that there are a few areas where this can occur: the hip, the femur, the tibia, and then the foot. So generally, they could either have femoral anteversion, which could be because the hip joint is rotated or because the femur is internally rotated. They could have internal tibial torsion, which is obviously from the tibia, and then they could have metatarsus adductus. And when you do your exam, you're going to examine each one of those to see where this comes from. And remember, it might not be just from one level. You could have multiple levels of rotational disorders, and all of them might have something to do with the problem. So if you take a look at the lower extremities in the middle picture, the right lower extremity, if I look at the knee first, so I'm looking at the patella, and I can see that patella is staring straight at us. And then the foot, of course, is completely rectus. Everything is straight. This person does not have in-towing. So that one is our normal. That's what we're going to compare to. Now, if you look at the other leg, the left leg of this person, the patella is pointing slightly internally. That means that if the patella is internal, either the femur or the hip joint are internally rotated. In this case, it's very slight and it's not causing an in-towing deformity at all. But you have to remember where the patella goes, or I'm sorry, where the femur goes, the patella goes with it. So that is the first thing that's going to tell me what location it is. So if I see the patella is pointing inward, then I know some of that has to come from the femur. If you look at the pair of lower extremities on the left side of the image now, so this person has rotation at two different levels. Now let's look first at the right lower extremity, which is the furthest left image. You can see that the patella is straight. Okay, so the patella is staring straight at you, but the rest of the extremity is twisted and the foot is in-towing. Well, that means that this has to be coming from something distal to the femur, which is the tibia or the foot. Now, if you look at this person's foot, there is no C shape, there's no metatarsus adductus, so it can't be coming from the foot, and that leaves the tibia as the remaining contributor. Now, if you look at the other side, you can see that the patella actually is heavily internally rotated, and the rest of the foot is in line with it. So probably this person has femoral anteversion or an internal hip position, and that is causing the in-towing to happen. So this person has different levels of deformity on two different extremities. Okay, so now we're going to talk about some illustrative, well, we were going to talk about some illustrative cases, but instead I'd like to maybe reward you for persevering in your studies with this really good topic. And I'm going to go over some test questions. So let's first look at this one. Which of the following radiographic relationships is found in Talipes equinovarus. Again, hit pause and you can kind of think about this for a minute. So a valgus first metatarsal is generally not something that we're too concerned with. It's typically a plantarflexed metatarsal that we might see in Talipes equinovarus. So that pretty much eliminates A and B. C, a decreased talocalcaneal angle is absolutely true. That means that both the calcaneus and the talus are increasingly parallel with each other. And a dorsiflex talus doesn't occur because the foot is in plantarflexion, which means that the calcaneus is actually plantarflexed. So that is the answer there is C. Now here's an X-ray to kind of show what that looks like. You can see that the calcaneus and the talus are both bisected with two lines, and they are parallel. So this has a talocalcaneal angle of 0. That parallel position is classic for Talipes equinovarus. And here's another one with a different child. Again, this is the talocalcaneal angle on the lateral radiograph. And just to point out, the first metatarsal is not dorsiflexed here. You could also see that the calcaneus is plantarflexed as well. All right, so you remember those relationships, and that will help you get through questions like this. Okay, which of the following is not a differential diagnosis of a child with rigid flat foot? So it is important for you to remember what kind of child has a rigid flat foot versus a flexible flat foot. They are entirely different. They're treated differently. A rigid flat foot typically ends up surgical, whereas a flexible flat foot more commonly is not. So vertical talus and tarsal coalitions are both rigid flat foot deformities. And Talipes calcaneal valgus is a very flexible one. That's the one where the foot has an up and out position, highly flexible. You can actually take the foot and move it up against the tibia. So there's your answer. Obviously not none of the above. Which of the following is true regarding the radiographic evaluation of Talipes equinovarus? So, distractor A says the talocalcaneal or Kite's angle is greater than 20 degrees in TEV. Well, 20 degrees is actually a normal talocalcaneal angle, and we know that the talocalcaneal angle approaches 0 in clubfoot, so that's not right. B, Simmons angle identifies the presence of hindfoot varus in TEV. That is not true. In order to identify hindfoot varus on a radiograph, you'd have to get a calcaneal axial. C, the rule of 15 identifies TN joint subluxation before the navicular is visible, and that is true. And we're going to go over that in just a minute in case that doesn't sound familiar. D, if Kite's angle is 0 degrees and Simmons is greater than 15 degrees, the subtalar joint is subluxed. Well, neither of those things tell us anything about the subtalar joint, so that can't possibly be true. So this is the rule of 15. And Simmons was a physician who looked at the radiography of clubfoot in order to help surgeons predict the kind of procedures that they would need to do, whether they were soft tissue releases or bony work or something like that. And he looked at the talocalcaneal angle and the talo first metatarsal angle. So the talo first metatarsal angle is Simmons angle. So as you can see in this image, the Kite's angle, or the talocalcaneal angle, is 0, basically. And Simmons angle is really large. That's much greater than 15 degrees. In fact, that's more like 85 degrees. if if the Kites is 0 and Simmons is greater than 15 degrees, then you can predict that the talonavicular joint is subluxed. And as you can see or not see in this radiograph, the navicular is not even there because this child is not 3 to 4 years old. So if you need to predict that the TN subluxation is present, this is the way to do it. So the rule of 15. So um, that kind of answers your question about the rule of 15. Which of the following procedures is commonly performed as a last step in Ponseti clubfoot casting? So a split tibialis anterior transfer is not done as a last step. And in fact, that procedure is sometimes done for relapsed clubfoot, typically at the greater than 4-year-old time frame. If the clubfoot casting failed, or more commonly, if the family was not compliant with maintaining the correction by bracing, then the child will start to invert and adduct again. And so they'll do a split tibialis anterior transfer to help that. So obviously that's not a last step. Murphy's Achilles advancement is a procedure that is not done for clubfoot at all. In this procedure, you are moving the Achilles 1 centimeter anterior to its normal insertion on the calcaneus. And what that does is it weakens the gastrocsoleus muscle complex in kids who have spastic equinus. So that's generally not needed for clubfoot. Peroneus longus transfer, it's just not done. There's kind of no reason to do that. And so that leaves us with D, tendo-Achilles lengthening. And in almost 100% of cases where Ponseti clubfoot casting is performed, a tendo-Achilles lengthening is done at the end. So you get rid of the cavus and varus, and then at the end of all that, you lengthen the Achilles to be able to dorsiflex the foot. Which of the following, which of the following is true when surgically approaching metatarsus adductus? A. Isolated soft tissue procedures are successful in children aged greater than 4 years. No. In fact, isolated soft tissue procedures are done in younger children, not in older ones. B. Abductor hallucis release typically accompanies all procedures. This is true. In many cases, because the foot is adducted, whether it was due to an abductor hallucis being tight or something else that caused the metatarsus adductus, the abductor hallucis is going to be contracted because it hasn't been stretched. So that is oftentimes required in order to help straighten the foot back out. Okay, so the C, just to show that whether or not it's true, located at the distal first metatarsal head, the growth plate is not of concern. Well, there's really no point in doing any metatarsus adductus surgery at the distal first metatarsal head because it wouldn't accomplish anything. And then finally, disruption of the joint spaces has no potential complications. Well, that's not true. Anytime you disrupt a joint space, you can cause stiffness, pain, and arthritis. And in fact, that very disruption of those joint spaces is a primary reason why soft tissue procedures are not generally done as much anymore, even in younger children. So, like the procedure, the Heyman, Herndon, and Strong procedure used to be very commonly done. It's done less commonly now because of that disruption of the joint spaces. Okay, so I'm going to move to final conclusions now, and I'd like to do those final conclusions by talking about today's musing. So this is what I'm going to end with, and so I'd like to talk to you about this question that I've heard for years. Why do I need to know this? That is a question. So whether it's learning the obstetric exam, Starling's Law of the Heart, or some trauma classification, there are always students arguing, what's the point? This is just extra info to cram into my already packed brain. Well, medicine, and that includes podiatry, is a knowledge based pursuit. Yes, you're going to do surgery, you're going to manipulate the structure of another person's body, and you're going to do great work with your hands. But without a mind to guide those hands, you're not a physician, you're a technician. More important than your hands is your mind. And using that mind well is going to consist of two primary mental skills: decision making, what some refer to as thought process, and knowledge base. Let's start with thought process. When you start your clinical rotations, you're going to have encounters with patients in which they'll tell you their story, and while they're talking, you're going to start coming to conclusions about what is injuring them or what their problem is. Then you'll do a physical exam, which will cause you to either modify your original conclusions or confirm them. Labs and imaging will come next, and by the end of the process, you'll have a diagnosis. In order to do this and be correct, you'll use the skill of sifting through all that information, keeping some and disregarding others, until you've created a clear picture in your mind about the clinical situation. If you get it right, you will have helped another human being, and what a gift that is. If you get it wrong, well, at least you won't have helped them, and at worst, you'll kill them. Patients will come to you and literally put their lives in your hands because of the bond of trust that exists between you and them. This entire relationship will depend on your ability to process information, think, and come to the proper conclusion. Now, if you're going to act, you'll need the second mental skill, knowledge base. This is very simple. If you don't know anything, you're useless as a doctor. How can you make a diagnosis if you don't know pathology? How can you prescribe a medicine if you don't know how to write a prescription? How can you bring a patient to surgery if you don't know how to manage the perioperative situation? The more you know, the better you'll do as a physician. A good thought process is useless without a solid base of knowledge from which to draw. Now, the good thing is, you have time to build that knowledge base. That's why podiatry training takes 7 years. You're given the time to train, practice, and study, and if you do it right, this will be plenty of time. Do it wrong, blow off the chances you have, go home early when you could have spent that extra hour in the hospital, or see one more patient, and you'll remain ignorant. Now, ignorance is your enemy. It will cause you to make improper conclusions. You'll miss what would have been obvious to other better doctors. If being ignorant is okay with you, then don't worry, because part of being ignorant is not knowing what you don't know. You'll be blissfully happy thinking you know, while behind you, you leave a trail of carnage. Don't want to be ignorant? Good. Then fight it. Fight for the rest of your career. You're going to be ignorant of some things. No one can know everything. But instead of succumbing to ignorance by being lazy and thinking, I know enough, lose your ego and absorb every opportunity to learn that you can. Listen to others who've come before you. Find those mentors that embody the principles of knowledge acquisition. Search out those experts who demonstrate excellence in their field, but have the humility to admit they're ignorant, and they hate that ignorance. Follow their example. Study the details. Learn the history behind the names. Learn those extra pieces of knowledge that might be helpful later. Appreciate that knowledge is more than just getting the correct answer on the test or seeking the highest GPA in the class. Instead, when you've been studying for hours and you're tired and stressed out and just want to stop, remember why you're here. Remember that in 5 months, you're going to begin the clinical part of your training. You're going to be part of a healthcare team whose job it is to improve the health and lives of other people. Whether you're effective or not in that pursuit will be entirely up to you. That is why you need to know this. And on that note, I thank you very much for your attention. Again, as always, please feel free to reach out to me if you have any questions or concerns. I will be happy to do everything I can to help. Take care.